Well, thank you. And we would like to really tailor this talk as a TCD basics for perfusionists. My disclosures, I definitely have some teaching consultation agreement with few companies. And because we are from Houston, I just want to show you when astronaut Kelly came back to Houston, we don't waste time. So we do a cardiac, carotid, and orbital ultrasound at the same time. So I think my love to ultrasound is definitely the priceless disclosure. And on the right, you can see a stunning image, what the ultrasound can show you. So this is not a CT scan. This is a frontal lobe transcranial Doppler image of a brain. To the right. So the first TCD was built by Dr. Elsley in '82. So this is not a new technique. And when the first TCD was built, it was a single channel TCD. This is on the this image right there. And about 2000, Mark Mooring gave us an M mode image. The M mode image is that red ribbon that what you see as a first screen on the top of the spectrum. And that red ribbon is really gives us the GPS for the entire hemisphere. So it's so much easier to find the signal because you have like GPS coordinates where the blood vessels are. So that makes our life so much easier to find the signal. And I think the underutilization of the TCD is really coming from the lack of training and lack of understanding how does this blood flow really looks like on that ultrasound image. So the ultrasound image, what I'm going to show you today is it looks like this, and this is the first publication that on the upper side you see the red signal when the ultrasound coming, the signal coming towards your probe, and these ultrasound signals basically reflects from the red blood cells. So the red blood cells, nice flat surface, give you a nice unique signature, and this is how we can measure the speed of the red blood cells. So we measure it in centimeter per second. That's on the bottom screen. And the centimeter per second speed measurement is actually almost similar to miles per hour. So a normal person, how you drive on a highway when it says 60, so that's kind of normal speed for our brain. The mean flow velocity we calculated from systole and diastole, and we have the expected range of mean flow velocity between 20 and 80. If a mean flow velocity as your speed limit goes above 80, we think there's a narrowing in a blood vessel. That's what brings this speed up. Or if you have a blockage, then when we go slower than 20, same like a traffic jam on the highway. The ACA is a blue signal because of the speed and the vessel flow is directed away from your probe. This is why your flow is blue, giving you a different direction. And I think the interpretation of these signals are depth, direction, and the resistance. Those are the key elements of how we can describe these TCD signals and screens. So this is just one more example that how a TCD screen look like. And what you see here on the right-hand side is the speed information. On the left-hand side, it shows you the depth of the signal was calculated, and the signal is represented by this yellow line. So that's the depth of the yellow line where the speed curves are received and calculated. And one more important information about TCD, what I think is differentiating from EEG, that it's really objective. So those numbers are real. So on the top of the velocities, we also have a PI values that tells you how much the vessel is open or how much resistance works the blood flow against. So these PI values are normal between 0.6 and 1.1. You can see it on the bottom of the screen. That's your normal. If the resistance is really minimal, for example, an AVM, this is when you have almost non-positive waveform, or when you have like a non-positive waveform, and you're going to see some examples on the pumps. When your PI are increased, the PIs will be like a chronic hypertension, increased ICP, going to shut down your diastolic perfusion. That's very important that we can again describe where obstruction happens. So during the case, if we monitor, we can pick up those occluded vessels without waking the patients up. And I think that's the advantage of TCD.
Mm-hmm. So can I just throw this out? So when they pick the heart up and they restrict the drainage from the superior vena cava, when they're really torquing it over to get to an OM graft or something like that, and our flow goes down, we're struggling for volume, and we're assuming, of course, I think reasonably, that the head is getting congested. Would you see that on that flow probe?
Exactly, and I think the TCD, I would call it almost like your centralized blood pressure read, because the brain is probably attracting about 25% of your total cardiac output. So if your cardiac output is down, definitely the TCD signal is going to show that. And forgot to show you, I just want to go back to the slide, that this delta percentage change on the bottom, if I push that for 100%, that would be my established baseline. At the beginning of surgery, even before anesthesia would start, the general anesthesia, that would be my 100% baseline, which would be the relative number that I don't need to remember what was my mean flow velocity. I'm just looking at, and I do not want to exceed about 20% flow changes. So 20% is what we can, again, communicate clearly that I have 20% drop, and that kind of alerting the anesthesia as well as the surgeons that we have a flow change. Quickly, I just want to show you that, and exactly similar, how do you see this blood flow change? Watch, I'm just going to put my fingers on the carotid. This is how the flow changes immediately. So why an EEG, you're waiting 2 minutes to see some changes. Here, the flow changes are immediate in milliseconds. So this is the normal flow pattern, and when I put the finger on the carotid, watch, immediately shows you there's a blockage. That blockage flow change tells you there's something between your measurement point and the heart which is blocking your flow. This systolic upstroke on the TCD waveform, that systolic upstroke assures us that the between your measurement point and the heart, definitely there's no blockage. And I think that's a pretty cool basic information what we're getting. And this is the other information I wanted to show you and kind of make it nice and clear to understand this blood flow pattern inside the middle cerebral artery and the ACA. Again, just one more time, this is the two carotid coming up, and this is the two MCs with the two red and two blue signals. Let's block the carotid. And in the moment you block the carotid, you're going to have a reverse flow coming from the other side, and this is how you can reverse the flow in the ACA. And now, even if you're colorblind, you can probably see that the waveform is switched from negative to the positive on the spectrum. So you see that the blue signal represented a negative value, while the red signal is a positive value. So you can see it's crossing and changing direction if it's needed. So I think those are the flow direction changes that we can quickly see. And this is, for example, if you're cannulating just the axillary artery, you expect to see bilateral MCA flow. But if your circle of Willis is not intact, you're not going to have, with single cannulation site, bilateral flow signals. So this is where the bilateral flow signals are must have, and this is why we are trying to teach our audience, because even in the vascular ultrasound schools, TCD is probably underutilized. There was a questionnaire by the Society of Vascular Ultrasound and Credentialing Societies about the 1,000 vascular labs running in ultrasound and answer the questions. Only 10% of them they even use for TCD as a diagnostic purpose. And even from the 10%, I would say the number of hospitals they use in TCD for intraoperative monitoring is even less. And definitely you and me, if I want to have any kind of surgery, my first question would be, who is the anesthesiologist, not just the surgeon, who is the surgeon, but I think it's very important as a team approach that someone is also looking after your end organ. I think the brain, you can fix my heart, but if my brain is blown and I have a stroke, I really don't care too much how successful was the surgery.
That's, and on type 1 dissections with deep hypothermial circulatory arrest, and you're talking about antegrade versus, of course you didn't mention it, but retrograde. So if you don't have an intact circle of Willis and you've only cannulated unilaterally and you're flowing along, you won't know until after the procedure whether or not you actually perfused the contralateral hemisphere of the brain.
And this is the slide kind of teaching exactly the same point that this is just the study of how many collaterals are missing. So let's say that about 50% of the people, they do not have a complete circle villus.
Wow.
That 50% is really a scary number, and sometimes we really cannot determine just by MR. So we're not gonna do MR just to learn if you have a circle villus or not. But in a stroke patient, when we study this, you can see that it's also predicting how good is your survival chances after the stroke. So if you have anterior communicator, posterior communicator, and even your ophthalmic helping out, all the three major collaterals working, you have a pretty good chance with all those collaterals you can survive a main choroid occlusion and stroke. But if you do not have those collaterals, almost your chances are 50% to even survive your first year after the stroke. So I think these are really scary numbers, and these are the numbers are also associated that not when you're looking at the extracranial stenosis, and we do screen for carotid disease before we go to the cardiothoracic surgeries, the carotid ultrasound screening is just not enough because the carotid is here, the carotid doesn't end up here. The carotid really hooks to the middle cerebral artery behind your eyes. So we are investigating only the extracranial part, and sometimes based on extracranial flow, we can predict maybe there is some disease distal, but I think to really look at the carotid ultrasound needs to be really combined with the transcranial Doppler to really see what is the blood flow doing in the brain. So the carotid is definitely not enough to investigate the blood flow in the brain for sure. And the TCD, again, is not a investigational device. These are the billing codes associated with a TCD, and this is, I think, since 2005. So this is not like last year. Definitely, I don't want to comment on those reimbursement and how does it change, but definitely each state has a different reimbursement rules. I can tell you that the TCD reimbursement is still better than a carotid, for example, probably for the reason that it's not as well utilized, but also not available everywhere. So I think they are awarding those people who are doing TCDs. And these are the billing codes that we do the regular diagnostic, the 86. But also, I think it's very important that I believe the TCD with the PFO testing probably can beat even the TEE to detect those PFOs or ASDs. The reason is real simple. So when you have an echo image of a 2D view of the heart, it's a cross-section. The bubbles can go on the front of that screen or behind the screen. You really need those bubbles to be able to cross and see those few bright spots on your echo. What we monitor with the TCD is the entire 3D flow pattern, and even a single bubble is enough to pick up in the brain. Bilateral or unilateral, doesn't matter, but we see these testing are done in the sitting position, so your Valsalva maneuver definitely has a better effect on you, and we do not have to sedate. So I think without sedation, definitely you can perform better Valsalva, and I think that also triggers a better response for us. The other important part is this breath holding index. When the breath holding index is with a simple 20-30 seconds interrupt your breathing, able to tell us how educated and how well trained your vessels. So the vessels needs to react immediately for lack of oxygen or the CO2 increase, and with that diameter change, the vasomotor reactivity can be tested. And our last, the emboli detection, I'm going to show you some example for emboli detection. First, this is the breath holding index. It's a real simple calculation. We try to monitor it on both sides at the same time. So with the same CO2 or hypoxia effect, will have the same effect, and you compare the two sides. And this is how the position the sonographer for the diagnostic TCD. We're sitting at the bedside at the patient head, and we start with ophthalmic, then we go to the transtemporal window, and finally the transoccipital window. And through these diagnostic tests, this is the different signals we can use for the purpose of monitoring in the operating room or even in the in our office. We do utilize a head frame, and later on I'm going to show you the head frame. This is just one more image for the submandibular ICA. that if you don't have temporal bone windows, we can definitely utilize the submandibular ICA, and also we use the submandibular ICA for the subarachnoid hemorrhage patients because that's how we can compare the flow, the intracranial and the extracranial pattern. And my boss, Dr. Lumsden, definitely a believer of transcranial Doppler monitoring, and we do all his cases under TCD monitoring, all the carotids, all the T-bars, and he believes definitely TCD is the best method for all the cardiovascular and cerebrovascular monitoring during the surgery.
Now, for the heart, now that's for his vascular surgery and carotids. At Houston Methodist, you guys are using TCD on all of your open heart surgeries as well.
Just yesterday, we had a type A, and it was affecting the brachiocephalic flow, so it was a stunning differences again between right and left. And I think those are the really easy confirmation that if you really fix the flap and that dissection is fixed, you will see the improvement of the flow right away. Or let's say that the dissection is progressing and the left side was not affected, but during the surgery, something happens that you see that the dissection progression too. So I think it's stunning that a live monitoring of the blood flow tell us if the origin of those carotids are affected. We do provide monitoring all our the TAVR cases. So the TAVR is more challenging because we started with a patient population average age of 85, 80. And especially the ladies, it's not a sexist comment, but suddenly we noticed that it's really hard to get through the ladies' skull. Probably the osteoporotic air pockets are blocking our ultrasound to get through the bone. This is why we came up with a solution that the submandibular ICAs, it's a good solution to really look and monitor those cases if you can get the signal through the transtemporal bone. And this is how a microembolus signal looks like. See that red dot in the middle of this waveform. So it means that the ultrasound signal reflected in the background from all the red blood cells. And it's just one single piece of embolic signal just reflected. It means there's something else traveling between those flat red blood cells. That could be a spheric air bubbles. There could be an irregular surface clot. We can't tell you what it is, but it tells me that it's something there we're not supposed to. So I think very important if you do a surgery, and yesterday we did a TCAR case also, that we're able to deploy a stent in a carotid without embolization.
Wow.
That's a winner for the technology and also a winner for us, that we are protecting the brain and able to do procedures with zero embolization. It means, hopefully, zero complication.
It's a winner for the patient.
And I think that zero complication should be our goal. So I think we shouldn't have something like, hey, 1% complication is acceptable. Mm-hmm. For me and for my brain and your brain, I would say 0%.
0%.
So, and I think we have that goal to really improve our new technology and investigate how we can make it better. And this is just one more example of how the embolus look like. And this is running in the middle cerebral artery, the red signal. The blue signal is in the AC, and this is how we're able to see them. And this is just for fun to probably conclude our first TCD session. Is because we are in Texas, so this is how damn easy to differentiate a cow here in Magnolia from a dolphin. If I see a dolphin, just not in the picture. So definitely an embolus needs to be moving together with the bloodstream. If the signal is sitting on a zero line, it means zero speed. So unlikely you get a speeding ticket for not driving. So you must have a driving and you must have a speed for your embolus signal. So the first signal, this is an example of the embolus signal, needs to be in the bloodstream. If something is sitting on a zero line, it doesn't go anywhere. So these are the examples, and you can see it doesn't give you a moving signal here on the M mode. It's just deleted because you are just having a jaw movement muscle or just stepping on a probe. Sometimes a blinking eye able to generate those signals.
And is there an angular component to it as well?
So the angulation is probably, you can see it on the embolus if you see that the proximal MCA, why it's traveling to distal, it takes time. So this is the distance from 60 millimeters to 30 millimeters. So that's only 3 centimeter trip. So this is not a trip to the moon, but it's just a trip to your cortex. While you're traveling that 3 centimeter, you definitely have like a forward slash kind of pattern that it takes time to get the 3 centimeters. And you can tell what is the speed, because the speed is here red on the right side of the screen. So it says 40. Sorry, you see underneath the tapping words?
Yes.
And this is where you can see that this is the scale for the speed. It's okay.
That died.
So that's my first part of introduction of what you see on the TCD screen. And with my second, yeah, it's moving again. So with my second lecture, I will return and going to show you more live cases, how we can utilize TCD technology in operating room.
I'm looking forward to that. So
Thank you so much.
You're welcome. Thank you.